Good evening, everyone. My name is Alistair Morton. I'm one of the general surgery registrars based in Nottingham and an NIHR academic clinical fellow. And for this month's Journal Club, I'm presenting the Chocolate Trial, a trial comparing laparoscopic cholecystectomy versus percutaneous catheter drainage for acute cholecystitis in high-risk patients, published by Charlotte Luzon in the BMJ in 2018. I tried to find a picture of some chocolate gallstones, but they didn't exist. So those are some chocolate raisins. So this evening, I'm going to briefly discuss the background of the paper, present the paper in terms of the results and the implications that may have on practice. So as we all know from our working experience at the moment, acute cholecystitis and gallstone pancreatitis is an increasing burden on emergency general surgery services. Studies going back almost as far as laparoscopic cholecystectomy becoming commonplace, so 30 years now, have started to compare acute cholecystectomy, that is within 3 to 7 days of presentation, with different thresholds set as acute, to delayed cholecystectomy, suggesting that acute cholecystectomy may be associated with shorter length of stay and comparable complication rates. The meta-analysis backed this up, showing comparable complication rates with early versus delayed cholecystectomy and a reduced recurrence rate of pancreatitis. This has led to many centres offering patients presenting with acute cholecystitis or pancreatitis and emergency laparoscopic cholecystectomy. Now, the initial evidence was all done within 3 days or 72 hours of presentation. However, some evidence has emerged showing that even beyond 72 hours, acute cholecystectomy for cholecystitis was safe and had a shorter length of stay, antibiotic duration, and cost compared to a delayed elective cholecystectomy. However, for older or frailer patients or more acutely unwell patients, acute cholecystectomy is seen as high risk. And often these patients, they have a harder decision to make about treatment, and they may receive a percutaneous drain instead to reduce the risks from an acute operation on the patient who is either very comorbid or very acutely unwell. However, percutaneous drainage does not definitively deal with the problem, as the gallbladder remains in situ. So there can be a large variation in practice depending on the patient, the surgeon, and the centre, and the access even to acute emergency lists for these patients. So for anyone who hasn't been to theatre before, who may be watching tonight, these are some images pulled from Google showing essentially what a laparoscopic cholecystectomy looks like, with 2 surgeons, an anaesthetist, and the patient under general anaesthetic, and what the procedure for a percutaneous cholecystostomy or drainage is, which is usually done by a radiologist in an interventional radiology suite under local anaesthetic. So the aim of the Chocolate Trial was to do a randomised controlled trial to assess whether laparoscopic cholecystectomy is superior to percutaneous drainage in high-risk patients with acute cholecystitis, the ones where there was more uncertainty about the best strategy. It's a multi-centre trial across 11 hospitals in the Netherlands and was run between 2011 and 2016. The purpose of the RCT was to demonstrate superiority of cholecystectomy against percutaneous drainage. So the patients who were included in this trial were those with acute cholecystitis and deemed to be high risk. Now, risk was judged by the Apache 2 score, which is a score that combines both pre-existing comorbidity with acute illness of the patient to provide numerical value, where the higher the value, the higher the risk for the patient. And consensus was deemed that a high-risk patient is one with a score of 7 or greater, but also that a score of 15 or above was very high risk, and would lead to too high risk of mortality. So these patients were excluded. So those that were included are those with an Apache 2 score of 7 to 14. Some other patients that were excluded were those with more than 7 days of symptoms, as the previous evidence was all about acute cholecystectomy within 7 days, as well as pregnant patients, those with decompensated cirrhosis or an acute intensive care admission with cholecystitis, and those who could not consent. So in terms of the methodologies of this RCT, randomization was done by an online module, by a centralized site coordinator, done by block and stratified by center. There was no masking of the trial, as it was an invasive treatment. It was deemed impractical and unethical to mask the patients and the clinicians involved. So the two groups, group A were the cholecystectomy group. They had a standard 4-port laparoscopic cholecystectomy done within 24 hours of presentation by an experienced surgeon, i.e. one does more than 100 procedures. So an experienced surgeon is one who did more than 100 procedures a year. Group B is the percutaneous drainage group. So they had an image-guided drain done under ultrasound or CT guidance within 24 hours of presentation by an experienced radiologist. However, there's no minimum requirement to be an experienced radiologist, as it was deemed that every radiologist in the Netherlands would have this skill set. The percutaneous drainage could be done by one of two routes, transhepatic or transperitoneal, and that was up to the individual radiologist who was doing the procedure. Emergency cholecystectomy remained a fallback for those in the percutaneous drainage group if at 48 hours these patients were not resolving or had worsening inflammatory markers or signs of systemic inflammation such as fevers. And those who were treated successfully with a drain were discharged with their drain in situ and brought back at 3 weeks for removal of the drain. So the primary outcome is 1 year mortality, 1 year biliary reintervention or recurrent biliary disease and readmission rate for that, and 1 month major complications. Those major complications are defined as abdominal abscess, pneumonia, myocardial infarction, and pulmonary embolus. The secondary outcomes, minor complications, surgeon-rated difficulty of cholecystectomy on a scale of 1 to 10, and the cost and healthcare resource utilization of both techniques. These outcomes were assessed by independent blinded assessors, and all patients had monthly follow-up for 1 year. And to briefly go over the statistics used, a power calculation was done based off the results of a previous study, suggesting to show superiority with an 80% power, 284 patients would need to be recruited. All analysis was done by intention to treat. That is, if a patient was randomized to the percutaneous drainage group, had a drain, and then had an emergency cholecystectomy due to failure, they would still be analyzed as part of the drainage group. All patients had the appropriate parametric and non-parametrical tests done, depending on distribution of the data. And there was a plan for interim analysis at 50% recruitment, with a plan to stop the study if the beneficial effects were highly significant. That is a p-value of less than 0.001. So the results of the study. So the interim analysis was done in December 2015, which showed a clear advantage for lap chole in terms of major complications. Therefore, the trial was stopped early. At this point, a total of 142 patients had been randomized and completed follow-up. 8 were excluded for withdrawal of consent or not meeting the exclusion criteria or had protocol violations. This left 66 patients in the cholecystectomy group and 68 in the drain group. And these groups were fairly comparable. However, the drain group was older and had more cardiovascular disease. So this is the consort diagram for the study. You can see of most of the patients with cholecystitis, a large amount were excluded for not meeting the criteria, for example, not being high risk. 142 were randomized and none were lost to follow-up. So in the cholecystectomy group, 64 of the 66 patients had their cholecystectomy. In 17% of these patients, their procedure was converted from laparoscopic to open. And the average surgeon rated difficulty was 8 out of 10. In the drain group, 65 of 68 patients had a successful drain. In 2 of these patients who did not have a successful drain, they were managed conservatively, and 1 went on to have an emergency cholecystectomy due to bile leak after unsuccessful drainage. In the drain group, those who had the drain, 93% had clinical improvement within 48 hours, and 1 patient did not and went on to have a laparoscopic cholecystectomy. So in terms of the primary outcomes, there was no significant difference in death, with 3% death in the cholecystectomy group versus 9% in the drain group, which is not significant. It's worth noting that both deaths in the cholecystectomy group were unrelated. For example, I think 1 died of an upper GI cancer. 3 of the patients in the drain group did, however, die related to complications from cholecystitis. Major complications occurred in 12% of the cholecystectomy group. However, they occurred in 65% of the drain group. This was a risk ratio of 0.19 and was highly significant when comparing the cholecystectomy group versus the drain group. And when this was adjusted based off in logistic regression for the differences within the groups, so the comorbidity and age, this was still very highly significant. So that risk ratio suggests that those in the cholecystectomy group had roughly a 5th chance of having a major complication compared to those in the percutaneous drainage group. In terms of the other outcomes that were analysed, there was more reintervention in the drain group by quite a significant margin, 66 versus 12%. And this excluded planned elective cholecystectomy. It is worth noting that in the protocol for this trial, the patients in the drain group were not given a planned cholecystectomy in the protocol, as the whole purpose of the trial was to see if they could be managed non-operatively. In the drain group, there were 11 emergency cholecystectomies and 20 elective delayed cholecystectomies. 16% of the drain group needed an ERCP within a year versus 9% of the cholecystectomy group, but this was not significant. But 22% of the drain group required an IR drainage within the year of their initial drain. And 53% of them had recurrent biliary disease, 41% of which of the total cohort required readmission, against 5% of the cholecystectomy group. There were significantly more readmissions and emergency room visits in the drain group. And the drain group also had 2-day longer length of stay at 6 days compared to 4 in the cholecystectomy group, which was also significant. To summarize the findings, the trial was stopped early due to the clear superiority of cholecystectomy versus percutaneous drainage interim analysis in terms of major complications and reintervention rates. There's also less readmission, radiological intervention, recurrent biliary disease, and length of stay in the cholecystectomy group when compared to the drainage group. The costs of cholecystectomy were also about £2,500 cheaper for the cholecystectomy group than for the drainage group. So this trial showed much better outcome for those patients treated with acute emergency cholecystectomy compared to percutaneous drainage. And this was in high-risk patients, so those who have either more comorbidity or are more acutely unwell. And it was associated with a quicker recovery, less complications, and less cost. It is worth noting that the drainage had an initially high success rate at 93%, but a large burden of longer-term complications, especially due to recurrent gallstone disease, over half requiring readmission or reintervention for this. The data suggests that all patients treated with drainage should be offered an elective laparoscopic cholecystectomy to avoid this. There are some limitations of the study, however. The definition of high risk only applies to a subset of patients. That is those with an Apache 2 score between 7 and 14, as those who were higher risk, that is 15 and above, were deemed too high risk for surgery for this trial. So this doesn't necessarily answer the question of what to do with the incredibly frail or acutely unwell patient. But it is worth noting that that was only 10 patients were excluded for being an Apache score of 15 or higher out of the 700 odd that were initially screened for eligibility. So it was small numbers who were that unwell. There's also no data on conservative management with delayed cholecystectomy versus acute cholecystectomy. So all patients were treated with the drain rather than antibiotics alone. And the treatment was not blinded, but there was blinding of outcomes. So acute cholecystectomy is associated with better outcomes than percutaneous drainage in high-risk patients with acute cholecystitis. And although this trial does not give any data on those very high-risk patients, they're likely to suffer from a high rate of recurrent biliary complications if they're treated with percutaneous drainage alone without a delayed cholecystectomy. These are the references for the background to the paper on some of the work that have been done around acute cholecystectomy. And now I'll leave it open for discussion. Thank you very much for listening to my presentation. I hope it's been helpful. And look forward to seeing you all at the next Journal Club. Thank you.